Good morning, everyone. Welcome to our Urology Without Frontiers and Functional Urology at Unicamp. Today we have a meeting together with University of La Sapienza in Roma. We have a guest professor invited, Professor Mauro Servigni. The topic of discussion today will be bladder pain syndrome. Very welcome, Mauro. And also, I represent Professor Mariana Taranto. She's professor at our university, Department of Pharmacology. So we have time today until 9 a.m. and we discuss two cases in the front. And after we have presentation of two professors and question after that. So I'd like to ask to Barbara Ferrarezi, our fifth grade resident in urology, to present the first case. Barbara, please.
Good morning, everyone. Can you see my screen?
Yes.
Okay. Well, the first case I'm going to present is a woman with 44 years old who reports multiple urinary tract infection in the past 2 years at the investigation. And the patient, she reported urinary tract for the last 2 years. She reports she had lots of episodes, but she drinks only one positive urinary culture. The other exams were all normal. Her medical history, she had 2 births, normal births. She had performed bariatric surgery and hysterectomy. At the physical examination, she had severe pain on palpation of the gastrin, bladder, and perineal musculature. Didn't have any prolapse or urinary loss, and she already brought to us an ultrasound, which was normal. Proceeding to the investigation, as the pain was the most important thing in her history. Initially was performed magnetic resonance because of the ultrasound was already normal, and this resonance only showed ovarian cyst with around 5 centimeters and a Bartholin cyst, which was just a curiosity, and no signs of endometriosis or no cancer. Then was performed the urodynamic evaluation. Here in the free flow phases, she had a normal flow, but the total volume was too low to give us a normal interpretation. Then the complete urodynamic, she didn't have any detrusor contraction in the filling phase, but when she got to the maximum capacity and was liberated to urinate, she had a flow of 20 milliliters per second with a complete voiding, but she had a post-voiding contraction, which was symptomatic, which is, according to ICS, a diagnosis of overactivity. And following the investigation, was performed a cystoscopy, which showed us just hyperemia of the vaginal mucosa with no lesions, nothing suggestive of cancer. but she had a hyperemia, and the wall, the vesical wall, was too strong. Then was performed a biopsy with and then made a compression to stop bleeding. And here we have the result of the biopsy. I guess Professor Athanasi could comment to us.
This is the mucosa of the urinary bladder. We see just a slight edema and a very slight inflammation, a chronic and specific inflammation. Let me see the other image, Barbara. A high power, the same. Edema, very slight, and a very slight, inspecific chronic inflammation. So the final diagnosis, just one or another mastocyte, but nothing that is sliding. And the final diagnosis in this case, please, is just a chronic and specific cystitis, a very slight. I don't know if in the clinical set that it was considered the interstitial cystitis. There is no specific anatomic finding for this kind of cystitis. But if there is any suspicion for interstitial cystitis, it may be favoring the inspecific findings. The important thing in this set, if you are thinking of interstitial cystitis, the biopsy is to exclude any other pathology, like carcinoma in situ, something like that. So the final diagnosis, it was a chronic and specific cystitis, very slight.
Thank you, Professor. Well, then she answered the pelvic pain and urgency scale, which she had 7 points of symptoms and 3 points of bothersome, with a total of 10 points, which is moderate to severe. And then the Larsen index, she had 5 points of symptoms and 8 points according to the problem. Then, after all the initial investigation, what to do next? How to treat this patient?
Okay, Barbara, let me ask you to Cassio Riccetto. Cassio, you need to do all the exams before start the treatment of this patient.
Good morning. I think the investigation have to be as most complete as we can, because the differential diagnosis is very complex in such a case. So it's necessary to evaluate the pelvis, because the association with endometriosis is too high in patients with concerns of pelvic pain. And cystoscopy is also needed too, because the first step to categorize a phenotype is to define if it's a Hunner lesion patient or not. So I suppose I do. It's exactly what I generally do with this kind of patient. And I used to start in this set with central opioid or something like this, or other kind of drug that modulate the pain reaction, the pain sensation, like gabapentin or something like this.
Okay, thank you, Cassio. I would like to ask to Mauro Servini. Mauro, the shows at the end of the voiding phase as contraction. when have symptomatic contractions end of your widening phase, how you treat the patient?
I think both computers are too proximal.
Good morning, everybody. About the question how to manage a patient with this functional disorder. It's very common in patients with BPS or chronic pelvic pain to have hypertonic pelvic floor, and in quite arrive to 60 to 70% of cases. This is the reason why should be managed also with a muscle relaxant on the pelvic floor, as well as to manage with, for instance, the heel massage. The heel massage is a kind of physical manipulation of the levator and eye muscles. So in order to allow the patient to relax and to perceive the situation of the contraction and relaxation.
Marcelo, I would Marcelo, I would like to ask you, what's the advantage to perform the questionnaire of pain or O'Leary? Is this important for what? Why you perform this type of questionnaire? No, you need to turn on your microphone.
If I understand the question, correlation between the questionnaire for patient with bladder outlet obstruction and this type of patient with a pain in the perineum. I don't know what the exactly correlation, but I think there is an important problem with this patient, okay? And the questionnaire is used only to quantify the intensity of symptoms, okay? I think it is very important, the symptomatology.
Okay, so you think it's good for the diagnosis, or it's more important for the follow the treatment?
No, I think it is to quantify the level of symptoms of the patient, no? And to speak the same language between the different countries, different locales of the evaluation of the treatment, no? If, for example, you have a level of symptoms before the treatment, and they quantify the improvement after the treatment, I think this is the real importance of the questionnaire. I don't know specifically Larry sense index symptoms. I don't know the specifically.
Okay, thank you, Marcelo. So, Mauro, you always ask for a help or consultation for the psychiatric in this type of patient?
Certainly the psychological or sexual support is absolutely important for those patients, because the psychological component is one of the component of the syndrome. And it's absolutely, I'm in favor to have a support from a psychologist as well as sexologist, because we cannot forget that the majority of patients, they have a lot of sexual problems due to dyspareunia, due to the lack of libido, and either in men as well as in women. And this is one of the components for the increasing rate of depression common on those patients. So I'm absolutely in favor of psychological as well as sexologist support.
Barbara, you have you already treated the patient. How is
Not yet.
She's broke.
At this time, she's waiting for what we're gonna do.
Okay. So we have discussed. We start with psychiatric evaluation, comportamental treatment, and how Professor Cassio said some drugs to decrease pain and control this. So, something also to report, Cassio? No, turn on your micro.
I think it's very important to refer it for physiotherapists. Barbara described a trigger point in the left side of the pelvis, if I remember. So it's interesting to have a physiotherapist. Here in our country, it's not so common to find psychologist or something like that is specialized in manage this kind of patient. But physiotherapist is used to do this work and give the close support that this kind of patient usually need. And they can use massage or electric stimulation and other techniques, no, to improve the treatment of pain. But the pelvic pain is usually reactional to the bladder pain. So we have to treat bladder also. That's the reason to start with a drug, an analgesic drug. There are others, and the treatment has to be tailored by the physician, and he has to follow up the patient very close, and is adapting the treatment. There is no receipt for this.
Okay, thank you, Cassio. It's very difficult cases, and very difficult because you need perform different treatments. So, Barbara, yes.
Doctor, a question. Please, what is the first line of medicine? What is the first line of treatment for this type of patient?
Okay, let's ask the Professor Mauro what's the first line treatment of this type of patient?
Microphone.
The first step is to relieve the symptoms, and because as we know, it's kind of a complex syndrome, so we need to take care about which is the bother symptom of the patient, and in majority of cases the main problem is the pain. But I would like to recommend, this is very important, don't treat the pain per se, but you need to treat the pain associated with the main management of the inflammation, because this is a complex inflammatory syndrome. So there are several protocols that I would like to show you in my presentation. But first of all, it needs to resolve the symptom, and in the majority of cases, the main symptom is the pain, and this is a mandatory.
Okay, thank you.
Okay, let's move to the new another case. You have a second case, Barbara. Could you present the new case?
Yes, sure. The second case, it's a woman which comes to her consultation when she was around 29 years old. She reports urgency, pelvic pain, and bothersome for over 5 years. She reports dysuria, urgency polyuria, and especially pelvic pain for the last 5 years. And she relates that became after urinary tract infection episodes. She reports she has to urinate at every half or 1 hour. She had difficulty to sleep, to work, and to deal with her daily routine. Partially because of that, she had never initiated sexual activity, and she had already used lots of analgesics with no improvement of the symptoms. At her physical examination, she had pain on palpation of hypogastrum and pelvic musculature, didn't have any prolapse or urinary loss, and we couldn't do a vaginal examination because she was virgin. The first exams performed was an ultrasound, which shows mild hydronephrosis, bilateral, and her urinal analysis was normal. Then the first steps was behavioral measures, and in the first consult was prescribed amitriptyline, hydroxyzine, and clothianidine, and we required urodynamic evaluation. Anyone, do you want to comment the first treatment, Professor?
Okay, go ahead to present all the cases, discuss our later.
Well, it was performed a video urodynamics because of the as we had a hydronephrosis. We rather to perform video urodynamics to see if there was also reflux, which she didn't have, and she didn't have overactivity. She had a good capacity, but at the voiding phase, she had her maximum flow was a little bit low, with the trigger contraction was also low, but she could empty her bladder successfully, with time was a little bit longer, like more than 1 minute to empty her bladder. When she came back, it was interrupted the use of clothianidine, and with the finding of a low urinary flow was added doxazosine, and was maintained amitriptyline for treatment of pain. At that point, she had around 2 episodes of ITU per year, and at that point, we referred the patient to the physiotherapy. At the physiotherapy, it was performed the TENS treatment, which is a transcutaneous electric nerve stimulation with a stimulation of tibial nerve, and also was performed a suprapubic, which is not yet comproved her efficacy, but was tested also for pain. And she performed the pelvic floor exercises for relaxation of the musculature, and kinesiotherapy, which is made in groups. She had a total of 24 sessions, Initially, it was programmed to do 12, but she didn't have an improvement. Was done more 12 sessions, and even after all that, didn't have any improvement of the symptoms.
Okay, perfect. So I'd like to ask to Leonardo, the patient not happy with the treatment. I would like to know what you think other treatments possible. I don't hear you, Leonardo. No sound.
Again, my mic is open.
Yes.
Can you hear me now?
Yes.
Yeah.
Yeah.
Go ahead.
So, yes. We can see someone is with the mic open. Please. Yes. So, I can't see any important problem at the urodynamics or something that can put the upper tract in risk at risk. So this is one point, but the second point is to take care of the quality of life and take care of the problems that take care of the. I would try to stabilize or decrease the sensibility or the sensations of her bladder. So I would discuss the use of medications like anticholinergics or alpha blockers to try to minimize the sensibility of her bladder. So I would discuss these aspects because we know that the case is complex. There is or there are many aspects related to also the emotional aspects of the patient, and I would try some drugs to add to the complex treatment of such patients.
Perfect. Okay, thank you, Leonardo. Cassio, again, what's your opinion about treatment of botulinum toxin in this type of patient?
I think this patient has a symptom pattern different than the previously one. The aerodynamics is very different. And before I go to invasive treatment like botulinum toxin, I'd like to have a bladder diary from her, a detailed bladder diary, because I'm not sure about the diagnosis yet.
Okay. Good. I want to have a question from the one listing of our meeting, Mario Henrique Martins. He asked, "Is possible to have the diagnosis of bladder pain syndrome when you have in the aerodynamic evaluation maximum systematic capacity less than 350 ml?" You can answer this, Mauro. Less than 350 ml in urodynamic.
Yes, of course, because there are several cases, different cases, and the bladder capacity is according to the severity and to the length of the start at the beginning of the syndrome, because there are some patients that they have a reduced bladder capacity, and this is one of the new evaluation item for BPS. 350 or then less than 350, it's possible, as well as a patient with 800 ml of urine. This is the old concept of the NIDDK, the American NIDDK, that evaluated according to more or less than 400 ml. But now it's changing, and 350 or less is a different criterion. So again, is a complex syndrome. So we cannot rely only to the bladder capacity, only to one symptom, only to the detrusor behavior, and so on. But we need to evaluate in a clinical fashion all the details of the patient.
Okay, Marcelo, you have a question? Go ahead.
Yes, I would like to question to Dr. Mauro. Is necessary all the time the use of urodynamic evaluation? Is necessary all the time the use of urodynamic evaluation in all the patients? Because the urodynamic is practically normal in this patient.
Thank you, Marcelo, for the question. It's a very interesting question. I'm actually one of the people involved in the ESIC, the European International Society for the Study of Interstitial Cystitis, and the ESIC relate the urodynamic only to patients with voiding dysfunction or in male with high residual volume. But I agree with you that probably it's important to evaluate functionally all the patients, excluding no one. In all our patients, we perform a complete urodynamic evaluation, including uroflowmetry, including pressure flow study, as well as cystometry. So it's really important because this syndrome affects also the functional behavior of the bladder.
I'd like to ask to Professor Sami Kari about Orient medicine. What's your opinion about acupuncture in the treatment of this patient? Please, your micro. Turn on your micro, yes.
I don't know about acupuncture. I don't have experience in that case.
Okay. Mauro, the patient not happy with this treatment. You prefer start with botulinum toxin or sacral neuromodulation in this case?
Professor, your
microphone, Professor Mauro, please turn it. Barbara, can you manage it?
I can't do that.
I would prefer the multimodal approach, taking care about the urothelium as well as the bladder wall, and the pain control. This is this multimodal approach has the greater chance to manage and to treat the patient.
Okay, thank you, Mauro. So we have time now. I believe everyone want to listen to you about your presentation, bladder pain syndrome from phenotype to treatment. So we are very waiting for you new thoughts about this subject.
Okay, you can see?
No,
not yet. No. I need to share the
presentation.
The presentation.
Put here. Yes.
Okay.
La tua presentazione è qua giù, no?
Sì, è dietro. Presenta ora. Ah, la devo mettere qui?
Sì.
Ok, allora, aspetta. La metto qui. La metto qua.
No, ancora no.
Ecco, qua. Lo schermo intero.
Una finestra davanti.
Condividi. Non mi condivide. Come mai?
Ma è minimizzata qua? Sì.
Sì, minimizzato.
Metti qua.
Però se sto qua.
Qua, questo.
Condividi.
Condividi.
Ok, perfetto. Ok.
Yes.
Vedi?
Sì.
Perfetto. Good morning, everybody. First of all, I would like to thank Professor D'Ancona, Professor Riccetto, and my great friend Paolo Palma for inviting me to this webinar seminar on the bladder pain syndrome that represent one of the more on these are my disclosure. Starting with I was one of the co-founder of the ESIC, the European, now became International Society for the Study of Interstitial Cystitis, Bladder Pain Syndrome. The bladder pain syndrome, the BPS, is the definition of Tagealde, like a hole in the hair, or a puzzle for people that they want to or a maze people that they face on those patients. But where we started from, in March 2003, there was the World Consensus Conference involving people from Europe, from US, and from all the part of the world, just define as much as possible the definition and the criteria for BPS. And on May 2003, in Europe, we found the ESIC, the European Society for the Study of IC. And we published 2 papers on the European Journal of Urology. And we create a new definition, not painful bladder syndrome, but bladder pain syndrome /IC. Is a chronic 6 months or more with the pelvic pain, pressure, or discomfort perceived to be related to the urinary bladder, accompanied by at least one other urinary symptom like persistent urge to void or urinary frequency, and confusable diseases as the cause of the symptom must be excluded. We had in 2005 a consensus conference again on the ESIC to rule out or to confirm the confusable disease, as you know, carcinoma, tuberculosis, and so on. In Asia, there was a different definition, hypersensitive bladder syndrome, HBS, that is a frequency urgency syndrome in which urgency is persistence and due to the fear of pain, and then related painful bladder syndrome to HBS with pain. the two authors that proposed the new nomenclature was Yukio Oma and Tomohiro Ueda. Then defined the HBS as a small subset of a broad umbrella of overactive bladder, a wet overactive bladder, and refer a hypersensitive bladder only to a small group of patients, and IC to a smallest group in which there was a through definition with anal lesions. So there are a lot of combination. I see BPS, I see BPS, BBS, but please don't say more painful bladder syndrome because it's the old definition of the ICS. In 2012, here in Rome, in Italy, I organized the consensus meeting just to create a possible homogeneous definition of BPS, including Asian delegates, North American delegates, European delegates. You can see Jürgen Nolling was the first president of the ESIC, then Jean-Jacques Windele from Belgium, that is a neurourologist, and actually in finishing his presidency, and now myself that I will become the new president of the ESIC. The pathogenesis of BPS is related mainly to three causes: the deficit, the deficiency of the glycosaminoglycans, the mast cell, or the neurogenic inflammation. The gag layer, as you know, they represent a urothelial barrier, and a defective presence of gag layer, they allow the irritating solids to enter through the urothelium, just creating an inflammation in the bladder wall. The mast cells are another important aspect, even though we will see recently make some doubts about their role in BPS. And neurogenic inflammation is a kind of antidromic firing with the release of nerve growth factor and substance P. And this is a very impressive neuroimmuno cascade in which you can see the gag layer and the bladder wall, and you can see at your left the mast cell with the granule of histamine that with some substance, the neuroinflammation, they release the histamine, releasing cytokines, nerve growth factor, and CRAC and other substances that create the APF, the anti-proliferative factor that reduce moreover the gag layer, and then they continue to create the vicious circle. Which are the ISC criteria? The urine analysis, voiding log, the questionnaires like O'Leary Scent or PAF, or the uric culture with cytology, the physical exam, and cystoscopy with hydrodistension, with a question about optional for urodynamics. But as we said before, I think that is absolutely important to evaluate also functionally the patient. Just about the question of the presentation, phenotyping. Phenotyping is absolutely mandatory for the patient, even though it's very difficult for such kind complex situation. Females and males with urologic chronic pelvic pain syndrome have distinct and different clinical phenotypes, and the Canadian group of urologists, they define the U-point system, evaluating the urology, psychology, the organ-specific infection, neurological, and tender muscle to evaluate as much as possible the patient. From histological evidence and to define the phenotype, there is a recent paper published by the group of Gopal Badlani, in which the low anesthetic bladder capacity, less than 400 ml, as we said before, could be a kind of phenotyping, because low bladder capacity were less likely to report systemic pain symptoms, and so subject to the low bladder capacity were significantly older with no significant gender difference. Female patients were the majority and more likely to have anal lesions. So, in conclusion, low bladder capacity with or without anal lesion may be a valid marker for the bladder-centric IC-BPS phenotype. We need to distinguish three clinical phenotypes. The problem related only to the bladder, the problem related to the bladder and bowel, like the IBS, and systemic chronic pain syndrome, fibromyalgia, chronic fatigue syndrome, etc., and so on. And more is the pain, more is the spread of the problem. Obviously, poorer is the quality of life. There is a very interesting paper published recently in which the systemic, the concentric problem of the bladder spread from regional pain syndrome to systemic pain syndrome. Why? Probably there is a visceral organ cross sensitization. So in terms that from the bladder, the problem is spread to the muscle with the fibromyalgia, the chronic fatigue syndrome, and also the autoimmune disorders like the Sjogren syndrome, the temporomandibular joint disorder, migraine, or hypersensitive or asthma problem. And the difference probably is the time, because more ready we approach the problem, more easily we have the possibility to concentrate only to the bladder and to treat dramatically. Short notes about epidemiology, because there is a wide discrepancy upon depending upon definition and methodology. You can see from Japan to Holland to USA, there is a huge discrepancy from, for instance, 34 over 100,000 people to 60 to 158. Why? Because one of the major reasons for such discrepancy is the lack of uniform definition of IC. And important, how you survey matters, what you ask matters, and most pelvic pain is not BPS. This is very important, remind. And you can see from symptom service to physician diagnosis, there is a huge discrepancy. Another important difference in terms of definition and criteria between USA and Europe, you see, because in USA, you can have a urinary marker or symptom score, and then they have a BPS-IC, while in Europe, it's mandatory to perform cystoscopy under anesthesia and urodynamics and biopsy. The biopsy is important to evaluate, even though not pathognomonic for the disease, but to evaluate the dysfunction. This is one of the sample of the glomerulation. It's typical with the bloody evaluation and the hypervascularity, as well the erosion you can see on the mucosa. And you see there is an lesion with the disruption of the mucosa until the bladder wall. This is the typical anal lesions. So there is actually currently a question about the role of glomerulation, because from 10 to 70% of patients with BPS do not demonstrate glomerulation after either distension. So in the conclusion, the specificity and the sensitivity is very low. And the score of the ESIC should be remove the glomerulation for the evaluate the patient with BPS. Also the mast cell are an important suspected cause of BPS, but more recently, some studies raised doubt about whether mast cell count are adequately informative to evaluate bladder disease, in BPS-IC with or without anal lesion patients, we propose lymphocyte infiltration and urothelium integrity superior to histopathologic criteria, as well as the density that are not able to differentiate BPS without anal lesion from, for instance, overactive bladder. So in conclusion, also the paper, very interesting paper recently by a digital quantitative analysis of mast cell infiltration, the conclusion of the authors where the mast cell density is not significantly different between IC specimen and non-IC control specimen. So the comment of Alan Wynne, as you know, one of the important key opinion leader on the world, another piece of uromythology is destined to die. So that means that mast cell is no more important. So glomerulation, we need to cancel. Mast cell, we need to cancel. Cystoscopy and androdistension, probably some colleagues in the US, they don't do, and biopsy as well. So which is the criteria for definition? I think, and we need to consider all the different items, glomerulation, mast cell, and hydrodistension and biopsy, just coordinating in a clinical evaluation. Is there an epidemic of BPS? Probably not. This is the rate of people with BPS in Japan. You see 3.5 over 100 centers. So the question is, to be or not to be? This is the question. Rare or not rare disease? In the European community, this is the patient organization by Loredana Nasta here in Italy that did a great job. This is the world prevalence of rare disease in Europe, USA, on Japan, and you see in Italy is 3.7. This is the national registry of the BPS, and so there is an evolving definition how patients are identified with the physician diagnosis and symptom-based questionnaire. So the prevalence is a moving target, and the future direction is to develop epidemiological screening tools and establish international patient database. Just shortly, a therapy. The therapy is to undefined problem and a finite number of solutions. First of all, the manual treatment is extremely important because, as we said before, the hypertonic pelvic floor is present in 60 to 70% of patients, so it's important, the physiotherapy, but mainly to relax the pelvic floor. For instance, with the TIL massage that can have an improvement in more than 50% of patients, and it's extremely important to allow the ability to relax, to contract, but to relax the pelvic floor muscle. Another important aspect is the diet, because acid foods as well as allergens or other alkylamine-rich food like banana, beer, wine, sour cream, or cheese or nuts are dangerous food. And this is a list of, for instance, of bad food, for instance, coffee, sweet, tomatoes, smoked food, acid food, while food selection, drinking water, or eat regular is a positive food for the patient. Which are the principles of BPS? To repair the epithelial dysfunction, to modulate the neural activity, to stabilize the muscle with bladder instillation, with tricyclic and with antihistamine therapy. There are a list of pharmacologic drugs like the oral therapy. The number one is the Amitriptyline, that is recommended as the first line oral treatment, as well as other proposals like, for instance, tanezumab, but that is promising but no more accepted because the phase 3 demonstrated no really efficacy. while has been a really great role for the BPS, the pentosan polysulfate, that is the only one drug accepted by the FDA American, with the dosage for 300 to 400 milligram a day. There are some phase study on the efficacy that should be related mainly to the multimodal therapy, not to the monotherapy. The cyclosporin is another interesting product, but mainly in refractory patients, because obviously, as you can imagine, there are a lot of side effects. About the pain, the question is not should the pain receive pain treatment, but why should she or he be left in pain? And so there is a kind of algorithm including several substances, and the gabapentin, pregabalin are some of the important approach on pain management. Finally, the intravesical treatment is several substances like the DMSO, the gag replenishment therapy, the liquid PPS, while has been quite abandoned the BCG, the resinteratoxin or EMDA. The lidocaine and so also the BioNiche on unpublished data, you see 61 success versus 80% placebo. That means the placebo is more effective than the drug itself. And there was a review published on Urology, Urodynamics about the gag replenishment therapy. And they said that the large trials of hyaluronic and chondroitin until 200 milligram failed to show efficacy. That means that the gag replenishment therapy doesn't work? I don't think so. This is a paper published on Urology, Urodynamics, a randomized clinical trial in which we have a cocktail, a shared substance, hyaluronic and chondroitin. You see, the hyaluronic is 800 milligram and chondroitin is 1 gram. That means this instillation contains 20 times more than any traditional instillation. These are the study in which there is a pain reduction, the superior for Aluril compared to the DMSO, the quality of life significantly improved, major for hyaluronic, as well as the safety, because there are no side effects compared to the DMSO, that is one of the more accepted and recognized treatment for instillation. And also there is a difference in terms of the disease stage, less than 45% compared to unresponsive, less than 26. So the pain reduction was greater, more reduction on visual analog scale, and the chance of becoming a responder with Aluril higher than with the DMSO. A few words about Botox, that level 1 evidence with the recommendation A, in sacral neuromodulation, level 1 evidence with the recommendation B, but we need to remind that it's still an off-label procedure. So in conclusion, to approach such kind problematic patient, we need to have a golden alliance with a multidisciplinary team, urologists, urogynecologists, physical therapists, psychologists, sexologists, gastroenterologists, neurologists, as well as pain clinic, because the patient is a complex patient, and only one treatment cannot be the sufficient effect on the patient. Obviously, to be continued because it's a route that we are doing, and I would like to all of you to enter in the Essex Society, because now it's becoming an international society, and patients interested in those complex fields are really welcome. Thank you for your attention, and I wait some questions from you.
Thank you very much, Mauro. Very excellent presentation. I would like to introduce Mariana Taranto, and I left the question for the end of the session. So, Mariana, I would like to start with what is current pharmacological approaches in this disease, what you are studying, what you are using experimentally. Mariana, please.
Hello, good morning for everybody. Let me share my screen. Just a minute.
In the meantime, a provocative question can be answered later until you share your screen. So the disease is complex. Can we solve the problem, making it even more complex with multimodal complex treatment, or we can hope to have more comprehensive treatment and make it simpler and make it easier for the patient? So just a question, a provocative question, a reflection, but can be answered at the end.
Okay, thank you, Leonardo. Please, Mariana, start.
Well, thank you very much. I really appreciate the invitation. It's a great pleasure to participate in this meeting and listen to you all, and especially Professor Mauro. So as mentioned, I'm going to bring some basic science and briefly talk about some pharmacological approaches for IC-BPS therapy that we are developing in our lab in the Department of Pharmacology of the University of Campinas. So by this time, I think we all recognize this is IC-BPS is definitely a complex disease, probably with multiple causes and patient phenotypes. So no new drugs are available for clinical use, and that's the focus of our research. Current in research, we want to understand what kinds of cellular signals play a role in IC-BPS, and these include inflammatory signals, oxidative or sensory signals, and also find out if there is any drugs that can be used for diagnosis or even for monitoring IC-BPS. So besides the slow translation into clinics, information from basic science is of great importance, as promising data based on animal models are frequently being published. And I understand the concerns regarding the animal models, but while a model it's not clearly the human, the information produced by these models has a profound impact, as they provide insights into the pathogenesis of a disease. And so despite the animal models of a disease rarely captures all the key aspects of the human disease, they are still very useful. So in our lab, we used a widely known animal model, the cyclophosphamide or CYP-induced cystitis. We have CYP-induced cystitis in humans too, which is obviously not identical to IC-BPS, but in multiple aspects, it corresponds to the human disease. So briefly, we use adult female mice. We treated systemically with a single dose of CYP, which is a chemotherapy agent, and CYP is metabolized and excreted mainly in the urine, resulting in local inflammation, bladder overactivity, and pain. And the main research focus of our lab is the nitric oxide signaling pathway, which is very important in many urogenital organs. And nitric oxide is a gas mediator that elicits its effects by activating an enzyme called soluble Guanilocyclase enzyme, which activation leads to the generation of cyclic GMP, which is a second messenger important in many processes. cGMP in turn targets the contractile apparatus of smooth muscle cells to induce relaxation, but also have effects on platelets and inflammatory cells too. So studies have indicated that impairment of this signaling pathway accounts for many lower urinary tract disorders affecting the bladder, the urethra, the prostate, and our first step was to evaluate in CYP-induced cystitis if this signaling pathway is compromised or not. And indeed, our results showed a downregulation in both gene and protein expression of guanilocyclase enzyme. And importantly, the bladders of these animals exhibited lower levels, significant lower levels of cyclic GMP. And at this point, we cannot conclude that this reduction in cyclic GMP is the direct cause or is the consequence of the bladder dysfunction presented in this model. But this shows us an interesting target that could be further explored. So we hypothesized by restoring these cyclic GMP levels, we can possibly restore the bladder dysfunction that we saw in this model. So there is two possible interventions to restore the cyclic GMP levels. We can increase its production or reduce its breakdown. There is a relative new class of drugs called the Guanilocyclase Modulators, which comprises the stimulators and the activators of this enzyme that can induce cyclic GMP generation independently of nitric oxide. And the main difference between these two classes, the activators and stimulators, is that the activators are able to induce the enzyme to produce cGMP even in oxidative conditions, when this enzyme is so compromised that are not able to produce cGMP anymore. On the other hand, we can also reduce the cGMP degradation, as the Pdf5 is the main cGMP hydrolyzing enzyme and finishes cGMP function. So both classes are already approved for clinical use. And we started treating our animals with the SGC activator called BPS5 also known as sinaciguat. It was developed by Bayer Pharmaceuticals. So we pre-treated our mice 1 hour before we injected CYP and wait 24 hours. Then we sacrificed the animals for ex vivo analysis, and we also performed urethane anesthetized CMGs with continuous saline infusion. We performed a lot of experiments, but just a few results here. These are systematic recordings in anesthetized mice. We have control animals as an example here. And we can see that CYP injection in mice revealed significant increases in voiding frequency and no voiding contractions, along with decrease in bladder capacity and void intervals. And we can see that BPS5 pre-treatment significantly prevents these alterations in these animals. In vitro, BPS5 also normalized the reduced carbachol-induced contraction. It's the same as cholinergic stimulation contraction in the CYP group and reverted these alterations. And we associated this improvement with the restored protein expression of both alpha and beta subunits of the guanilocyclase enzyme, along with a normalization of the cGMP levels in the bladders of these animals. So it led us to suggest that maybe SGC activators could be a nice approach for IC-BPS. And the other available option to increase cGMP levels is the Pdf5 inhibitors. There's an interesting discussion about PDS and LUTs, as the PDS, especially Pdf5, is widely expressed in urogenital organs. And Pdf5 inhibitors are generally safe, well tolerated, and easily available. And it's the standard treatment for erectile dysfunction, as has many beneficial effects for LUTs secondary to ED or BPH. And we know that Pdf5 inhibitors improves urethral and prostatic smooth muscle relaxation. It reduces the detrusor spontaneous contractions and increases the blood flow. Besides, the mechanisms are not fully described. And it probably mediated by different secondary signaling pathways. But regarding CBPS, the role of Pdf5 is actually unclear. So we are carrying out experiments with tadalafil, one of the Pdf5 inhibitors, and I hope to share these results soon, but I don't have they ready at the moment. But about these cyclic GMP modulators, there are still many questions that we need to address. And we need to understand, for example, the mechanism of action of these drugs and how they improve the symptoms. And if it's through the modulation of afferent activity or downregulation of contractile mechanisms, for example, the urokinase signaling pathway, or if it involves organ blood flow, inflammation, or oxidative stress. And especially regarding the Pdf5, we need to understand how they work in women, right? Because for men, the mechanisms are widely described. This is a very interesting study. It is a very well-controlled trial that evaluated the efficacy of sildenafil for ICBPS patients. The patients are divided in two groups, the treatment and the placebo group, and they receive a low dose of sildenafil every day for 3 months. And we can see that both the symptoms and the problem scores, as well as the urodynamic scores, in these patients treated with sildenafil were improved, significantly improved after 12 or 24 weeks of treatment. So these are stimulating results. I'm afraid that this is the only clinical trial that evaluated the effects of Pdf5 inhibitor in ICBPS patients. But this inhibitor seems to be effective and well-tolerated therapy for ICBPS. But we need larger clinical trials, as this study evaluated only 24 patients, but seems to be a very nice alternative for these patients. So as human tissue is crucial for validation of potential biomarkers that we have found in our animal model, we recently initiated a collaboration with Professor D'Ancona to evaluate in IC patients the same targets that we are investigating in our animals. We are just in the beginning. We're still recruiting patients. We have only a small sample of patients yet. But I just want to share this initial data of a comparison of gene expression in control and IC patients. So we have 7 control patients, which is derived from healthy patients or cadaveric donors. And we have 3 IC patients with honey lesions. And we are trying to construct a panel of gene expression. And besides the small sample size at the moment, we have interesting results as we identified here lower levels of beta subunit of guanilocyclase in the urothelium of these patients. And we also found an increase of the expression of phosphodiesterase 5. So PDA5 seems to be increased. So we might have a reduction in cyclic GMP production and an increase in cyclic GMP degradation in these patients. This is very interesting and comparable to our results in animals. We are planning to quantify also the cGMP levels in these samples in the future too. We also found an increase in TNF-alpha, which is a key inflammatory molecule, and also in NOX2 and NOX2 subunit, P47-FOX. They're both involved in reactive oxygen species generation. And we know that inflammation and oxidative stress both contributed to an impairment of this signaling pathway, to the impairment of cyclic GMP generation. So we have several analyses to perform yet, and maybe a clinical trial with the drugs that increase cGMP might be interesting in the future too. And to summarize, we know that impairment of cyclic GMP signaling accounts for lower urinary tract disorders, but the role in IC BPS is still unclear. In CYP-induced cystitis, an impairment of this signaling is observed. Along with voiding dysfunction, we see destructure, hypocontractility, and inflammation with some similarities with the human disease. CGMP levels restoration by SGC activator improves cystitis-induced alterations in mice, and experiments with other alternatives to increase CGMP levels, which includes tadalafil, are current in progress in our lab, and I hope to share some results soon. But for clinical translation, larger and more focused trials are needed to improve the current evidence. And if nitric oxide CGMP modulators might constitute a promising therapeutical approach for cystitis management. So I finish here, and I would like to thank again for the invitation, and also to thank my supervisor, Professor Edson Antunes, and my collaborators, Professor Fabiola Monica and Professor Dancona, who always collaborate with us, and as well, all members of the Urology division. And I thank you, everybody, for the attention, and I'm open to questions.
Thank you very much, Mariana. Excellent presentation. And you open a new way to see this patient and probably to treat this patient. So I want to open to questions for the board, for everybody. Marcel, you want to ask a question?
Yes, I want only a question for Dr. Mauro. Dr. Mauro, thank you for brilliant lecture. And I want to know, in your opinion, in your clinical experience, when we start the psychological evaluation of the patient, in the beginning of treatment, in the middle of treatment, in all the part of treatment.
Okay. This is a very interesting question, because focus on one aspect that we as a physician, we very often forget, but for what we know, the psychological or sexological component is another an important component of the syndrome. So the question is before, in the middle, or the end. I think that those patients should be treated in the multimodal approach. The multimodal means that we need to have the more component, and at least according to our experience, we do a thorough evaluation of the syndrome once we assess the degree of the disease, because if 50% of severity, probably we do prefer to postpone the psychological aspect, because sometimes with the only medical treatment or medical and physical approach, the symptoms, they disappear in the majority of cases. Okay. While if there is a severity of the syndrome, for instance, from 60 to 70% of severity, then we need to combine the medical management, the physical management, as well as the psychological management.
Okay, thank you. Understand.
Because this patient has this symptom for many years, maybe they have pain from the brain, or brain pain, because a long time pain, you have a memory of the pain. How you treat the pain or memory of the pain?
This is a really interesting and exciting question and difficult question to answer. But we published recently a new approach with I didn't present for the limited time of presentation, but we got the experience with transmagnetic approach. Is a new treatment, a new modality to treat the pain that is becoming a neuropathic pain. After we discovered that 1.5 years of BPS, of pain, the pain is maintained by the brain. So it's important not to treat peripherally, but to manage in a central way, because the central nucleus of the brain, the thalamus, the gray matters, and the amygdala, they maintain the vicious cycle of the pain. So we started with a pilot study with the colleagues of the neurologic department, just with the two coils applied to the skull, and the results are very promising in terms it's like to with the computer to reset the file, and the pain was reduced dramatically. So it's a new option, but you can see that there are a lot of new opportunity, because until now we don't know exactly how this troublesome problem is related only to the bladder, only to the brain, or is a kind of a puzzle.
Mariana, you address a new drug to treat this difficult patient. You expect to have some improve of the symptoms after how long which Pdf5 inhibitors? You need to wait how many weeks to have something to movement, to see the changes? I know you are in the lab, but probably you know the pharmacology and how long you need to see the results.
You're asking me about the results in animals, right? I'm sorry. You're asking me about the results with animals, right?
No. You from pharmacological point of view, you need to wait how long to see the effects of Pdf5 inhibitors. And also, you use high dose of PDF. In this case, you suggest to use probably high dose on regular dose.
There is just one study that carry out some experiments with some clinical trials with women with ICBPS, and they used a low dose of Pdf5 inhibitor. They used sildenafil, and they saw some improvement after 12 weeks of treatment. But actually, I believe that it's better to use actually tadalafil instead of sildenafil, due to the higher specificity to the Pdf5 and reduce the side effects, and also to the longer half-life of tadalafil in relation to sildenafil. So maybe sustaining this drug for more time in the patient's circulation, we can see some results actually shorter than this sildenafil study. But I believe that in just a few weeks of treatment, because the patient is still able to produce cGMP, so you just will inhibit the degradation. You don't have to restore an enzyme function or wait for turnover of the enzyme. So I believe that the question is about 8 or 10 weeks, 2 or 3 months of treatment is more than enough to see good results. And we can see that there is some reduction not only in the voiding symptoms, but also in the pain. There is a lot of studies showing that Pdf5 inhibitors actually have some analgesic effects. So I think there is a very nice alternative for these patients.
Okay, thank you. Open for other questions.
I'd like to ask you to Professor Mauro and also to Mariana about the role of immunomodulation in such patients. In the past, corticoids were applied without success, then cyclosporine, but now we have a lot of monoclonal antibodies. Mariana told about the expression of some cytokines in her experiment. So I'd like to know your thoughts about this subject.
Can I talk first?
Yeah, maybe you're lady.
So Cassio, as you can see in my presentation, I saw both in animals and also in the human samples that we already collected a highly significant expression of TNF-alpha, which is a very important cytokine and involved in many inflammatory processes. And there's a lot of attention about the role of TNF-alpha in many diseases, many inflammatory diseases now. And we have available monoclonal antibodies to TNF-alpha. There's a drug that is already approved to treat rheumatoid arthritis. And but it is a very expensive drug, and I don't see many studies with this drug in preclinical or clinical models. But I believe that it's very important this as a target, this TNF-alpha. And you saw with only 3 patients, I saw a significantly difference between the TNF-alpha expression in urothelial samples of IC patients. So I think it's a very important target, and undoubtedly the immune modulation in these patients is very important, I believe so.
Okay, thank you.
Thank you, Cassio. This is a very, very terrific question, because one of the option was considering the BPS related to the immuno complex syndrome, but unfortunately, all the experimental or the clinical study, they didn't demonstrate the real effect of the neuroimmune system on the developing or the maintaining of the syndrome. There is no doubt that there are some important clinical manifestation, like, for instance, the rheumatic syndrome or the Sjögren, as well as the fibromyalgia or the chronic fatigue syndrome, that represents a kind of interaction with the immune system. But, for instance, the cyclosporine, as well as also some immunosuppressant drugs, also the monoactive antibody, they didn't demonstrate any real efficacy. The main problem, as the title of my presentation, is to phenotyping. The phenotyping is absolutely mandatory, but until now, we don't know exactly how to define those patients, because there are some tentative with the U-point, with the new paradigm of clinical evaluation of bladder capacity, or the new option of, for instance, the nitric oxide in anal lesion. But there is we need to understand that actually currently October 2020, we know exactly two things. First, that the disease is a broad umbrella in which there are a lot of things inside. It's completely different from the chronic pelvic pain. Chronic pelvic pain is another story. BPS represent one part of the chronic pelvic pain, but is not the same. First, the second one, that is we have two distinct phenotypes. One is the patient with anal lesion. Anal lesion are absolutely interstitial cystitis. That's it, interstitial cystitis. Bladder pain syndrome is a different story. There is no anal lesion. The role of granulation, as you know, is debatable. The role of mast cell is debatable. And so it's important at the end of the story that people, they approach those patients, they need to be expert on the field. Not a general urologist, not a urogynecologist, not a gynecologist cannot approach the patient because they are very complex. It needs to focus on function or dysfunction of the bladder pain, the bladder as well as the pelvic floor, because they are combined symptomatic clinical features. And second one, the people expert on the field need to have also a comprehensive vision of the patient, not only physically, but also, as we said before, psychological as well as sexological, because it's important, because the patient is the only one, and we need to cover all the aspects.
Thank you.
We do a big revision of this syndrome. I would like to thank very much Mauro Cervigni and Maria Taranto. Beautiful presentation, great discussion. Thank everyone. I would like to end the session. I invite all of you for the next Wednesday meeting. Thank you very much for all of you. See you again next week. Thank you. Bye-bye.
Bye. Bye.
Bye-bye. Thank you very much.
Bye.
Bye. See you later.